Dr. Daniel, I think we can start. Dr. Thieblé, please stop sharing.
Good afternoon, good evening, and good morning, wherever you may be. I want to welcome you to this important capacity building of health emergency workforce across WHO Afro countries. I am Dr. Ebenezer Daniel, and I am representing the incident manager of mpox in WHO Afro, Dr. Solomon Fisea, and I'll be taking this welcome note very briefly, and I welcome you once again. Now, mpox synopsis, generally going by the epidemiological history, this disease has been endemic in Central Africa since 1970. And of course, it got worse in early 2022, affecting 112 member states, in which we have 13 African countries among them. Now, it was declared as public health emergency of international concern in July 2022, and this for two major reasons. One is that this outbreak was reported with a sharp increase across many countries, especially those who are not reporting previously, and that there was knowledge gap about the information surrounding the epidemiology, and yet we keep having increased transmission. So there was this knowledge gap, and so we needed to do something about it.
Doctor, sorry to interrupt you.
Yes,
but
please.
Could you please go on slide? It's on slide 1. Okay, thank you. Sorry.
Thank you, no problem. So the situation got worse in 2022, as I said, and it affected 13 African countries. And then we actually need to now bridge the knowledge gap that is existing as far as this disease is concerned. Fortunately, in early 2023, this disease was declining globally, and the status of public health emergency of international concern was removed, but this actually did not stop the continuous increase in the incidence of the disease in WHO Afro countries. Now, why should we be concerned? Or why are we actually organizing this seminar? One is that in Africa, there is a kind of gap in our data in the Afro region, and it's hampering many things. And this is affecting the evolution, the transmission, and the management itself. The zoonotic and the human-to-human transmission in African countries, with historical transmission, it continues. And so we need to intervene by continuous research into this particular disease so that we can understand the epidemiology and the potential driving factors. It is also good to note that the continued spread and expansion of mpox in our region is very concerning. So there is also the new development in the mode of transmission, which is becoming so dynamic. The evidence recorded on the sexual transmission is one that we need to take note of, and that the epidemiological concomitants of monkeypox among different populations with special diseases, or what I can call the sexually transmitted infections, is becoming more worrisome. For example, people living with HIV and uncontrolled HIV, especially in the underserved and low setting, is also very concerning. So the lack of access to vaccine and new therapeutics is another factor that is giving us the concern in WHO Afro. So what are the key considerations in control and halting the transmission, probably elimination of this disease in WHO Afro? We need to note that we don't actually need to reinvent the wheel, because we have ongoing strategies that we can adopt. Why? Because we have existed the integrated health services with an emphasis on primary health care and public health functions across all our WHO Afro countries. So what does that transmit to is that there is existence of comprehensive, promotive, protective, preventive, curative, and rehabilitative and palliative care, the blocks that makes up our primary health care, that we can actually use as templates for interventions. And strategically, we also need to prioritize the healthcare services that is actually aimed at individuals and families. And this way, we can actually manage this disease in our countries more strategically. It is also good to note that the multi-sectoral policy and action is there for us to harness, and that is going to address the broader determinants of health, be it social, environmental factors, and various individual characteristics and behavior, and at the same time empowering the people, families, and the communities will also help us to optimize individual health and collective health as it may be, and this is going to help us a lot in bringing a lot of advocacies and policies on board to counter disease. Now, let me begin to round up by saying that it is good to remind ourselves on these two important documents which we can check: the Director General of WHO standing recommendations, and I know Dr. Lewis will be coming on board soon to tell us a lot about what is happening in terms of all these recommendations. Then the communique from the recent high-level ministerial meeting, which was held in Africa, Kinshasa, DRC. And I want to say at this juncture that it is very hopeful that these documents will help us and guide us on the next direction that we should go on the management of this disease. And I want to welcome all of us one more time. And I believe that this particular training is going to equip us and give us a better capacity to be able to manage mpox in Africa and globally by extension. Thank you so much at this juncture. And with these few remarks, I want to say welcome one more time and thank you all for listening. Thank you.
Hello, Mohamed. Good morning, Mohamed.
Yes, Dr. Thieblé.
Okay, yes. Okay, I will just crack on with the housekeeping. And thank you very much, Dr. Michel, for the great welcoming remark. And dear colleague, thank you very much as well. I can see we have almost close to 300 people, participants join. For such a reason, it is important to know some of the in-house rules, how we use this webinar, and your support as well, how it is important. And the webinar, as you say, it will start on 23rd, and you have our colleague, Dr. Michel, Dr. Rosamond Lewis, who is the technical lead, and you have Dr. Diallo as well, Mamadou Saliou, and those will not present, the other colleague will present the coming days and week. So before starting, it is important for everyone, participant as well as panelists, to know that this virtual training adhere to some of the rules in WHO and United Nations agency as well. And those are to follow the code of conduct to prevent harassment, any form of harassment, whether you chat or you speak out, it is not allowed. Harassment is not allowed, and sexual harassment as well. I know that's very rare on online form, but it does happen. Please obey to those rules, whether it is during this webinar or even after this webinar, whether you work for any UN agency or WHO or even at your normal workplace, because United Nations take it very seriously. Now, if you look carefully on your screen for Zoom, you will see some icons. One is chat, one is your hand. You can raise your hand when it comes to question and answer session. Then you have question and answer here. You have the globe. The globe, I will describe this one. I will talk about this quickly. And then you have the chat. This chat where you see one, for example, that's only if you have IT or logistic issue. Now, question and answer, that's where you put your question. Then panelists will answer some as we go along. Then you will have also live panelists where they will speak. You can see them answering. But you are free to put your question using this. But we have not noticed that some people put chat here, but we will look at it. But the best one is you put your chat here. Now, the globe, I will describe this globe here. You have interpretation for those who speak English, and for those who speak French, and for Portuguese, just put it in the chat box. We will take it, we will translate it using the available package. But for French and English, you just click on one of these. If you want French, for example, you're gonna click here. If it doesn't work properly, you can put that one using the chat here. You just click and type, it doesn't work. We will look at it. If we can address it quickly, IT colleagues are with us. So interpretation in English, it is well written here. Please don't ask those questions again, because it is very important if we read, and we don't have to ask all the time. You just read here and you use the globe rather than say how to get in. It is here, the introduction for those who join already. People who will join late, and I think we will text for them. Now, you can see here the interpretation, and all the proceedings serve to facilitate communication. And don't judge us or the organization, the authenticity of the translation. Sometimes people have that approach as well. Now, here is, if sometime when presenter talk, they present, you can, if you click here, you will see the caption. I mean, sometimes you see the word being live transcript, but you don't need it. You just need to focus to follow it, and I think you will gain more than if you try to read. And but you can hide it, or you can click and see, and it will help as well. For presentation, don't worry. All the presentation will be recorded, and it will be shared as well. The presentation will be shared in a PDF format, but then you can go to the link as well to look at it again, to follow it. But the training will be useful for all of us. And you can see the session will be recorded. So if you don't want to be recorded, then you have to think twice if you want to give your question live or you want to type it. Okay, the record will be shared. The recording will be shared after the session. And so again, the material will be shared. It will be emailed to you. You can download it. But if you receive transfer file, please just download it quickly because it might expire in a few days. So you don't have to download it, save it somewhere, your online Google Drive or OneDrive or Dropbox, save it wherever you want to save. Now, here, your feedback is very important to us because without your feedback, we won't be able to improve. So make sure if you give feedback, it doesn't need to be criticism, but it is always, well, I like this one, I don't like this one, you could improve on this. We learn from each other. Please, we will not take it badly, really. It is the job of all of us. Okay, now here is the agenda for today. You can see we will stick to the time. You got the welcome remark just given now, and the webinar training you have seen what you need to do, where you need to put your question, and where you need to address. If you want to raise your hand, you can do that, and the presentation will be shared. And the protocol, please stick to the code of practice. That means no harassment. If you don't like something, just address it in a manner which really will be acceptable. And it is that will help all of us. It is interactive. So Dr. Luis Rosamond will present on the standing recommendation and the framework, and then you will see next, you will see an interactive session by Dr. Mitchell Muteba, and followed by Dr. Mamadou Diallo and Mitchell again. They both will present on epidemiology and transmission of the disease. Of course, it will be in human. Then if they want to, they can touch on transmission in animals if they have data. Yes, I will be looking forward to hearing from them as well. And question and answer now, I will moderate that one with Dr. Daniel Ebezener. And I think then we will stop there. And really your contribution is very important. We have done this in the past, but we want to improve on whatever knowledge we have. Okay, over to you, colleague. I will stop here. And unless you got a burning question about the methodology. But that's the standard methodology we use for all webinars. Just we try to respect the protocol in terms of communication. Okay, over to you, colleague. We will move to Dr. Rosamond Lewis, the technical lead. And okay, I will stop sharing. Mohamed, please.
Yes, please, Dr. Rosamond, go ahead.
Bonjour à tous. Est-ce que ça va? Vous m'entendez bien et vous voyez la présentation?
Parfait, c'est parfait.
D'accord. Je parlerai en anglais, mais je vais d'abord me présenter en français parce que je vois qu'il y a beaucoup de collègues congolais sur l'appel. Donc, moi, je suis chez vous à Kinshasa aujourd'hui, malgré les diapos en arrière-plan. Et je me fais un plaisir d'avoir été parmi vous pendant 2 semaines. à appuyer le pays, le niveau national, le ministère de la Santé, à travailler la réponse par rapport à la variole simienne en RDC. Okay, so just to confirm, we shouldn't have two videos there. So it should be okay. You should be able to see me and hear me. Can you confirm, panelists, please?
We can hear you, but we cannot see you.
Mohamed, I can see. Rosamund.
Okay, from the other device. Perfect, sorry.
Yes, I can see as well. I can see. All right.
Okay, I think everybody has it okay now. So thank you very much. So today I'm going to just give a brief introduction, which is to talk about the overview, the directives from the Director General of the World Health Organization, and the upcoming strategic framework for enhancing control and achieving elimination of human-to-human transmission of the epidemiology globally. And I have other slides, which, of course, I will go into some of the issues of the standing recommendations as well as a strategic framework. Most of the epidemiology will be presented by my colleagues after me. And so this is really, from an epi perspective, just a very brief overview. So just to remind us all that we have actually been experiencing a global outbreak of mpox since May of 2022. And this slide illustrates the extent to which this has been multi-country, global, and reached all 6 WHO regions of the world. If you look at the numbers and the map on the left, what you see is that as of February 2024, and the March data will be coming out next week, but as of February 2024, and since the beginning of 2022, there have been almost 95,000 confirmed cases, laboratory confirmed cases of mpox reported by 117 countries around the world. So this is evidence, obviously, that something that is even a zoonotic disease can evolve to become an infectious disease that transmits from person to person. In this global outbreak, only 181 deaths have been reported, again, among confirmed cases. This clearly does not reflect the burden of disease of suspected cases, clinically compatible cases, undetected cases, and so on. And we will discuss the burden of disease in the African region afterwards, which is clearly much higher than where it is globally now. So on the right-hand side, what you have is the data of just February 2024. And even just in February 2024, there were still 29 countries globally reporting mpox. This includes the African region, but again, these are confirmed cases. So 715 confirmed cases were still reported globally in just the last month. As we see here in this epi curve, we have a beautiful classic epidemiological curve of cases against time, and we see this dramatic increase in the number of cases of mpox reported globally from May through to the end of 2022 and beginning of 2023. The colored bars in the epi curve on the left represent the WHO regions. So in blue, we have the region of the Americas, and in red, where it all started, the region, the European region. Prior to this, there were some seeding events from Nigeria. So the clade 2, the West African clade of the monkeypox virus, was actually already causing some seeding events in a few European countries and North America since 2018 to 2021. There were about 8 or 9 such events, and very little secondary transmission, but there were a few cases of secondary transmission to a health worker and to a family, for example. In the global outbreak, which then began in 2022, we see that it was actually controlled with a lot of effort on the part of many people, but the evidence of control is also there in the epi curve. However, since 2022, the number of cases has stabilized at a low level, The virus continues to circulate, as I mentioned. Almost 30 countries are still reporting, but also there have been increases now recently in the last few weeks and months, even in the originally affected regions. What you see on the right here, up to the end of February, is again the last 6 months and what it looks like on a different time scale. So you see that in green, the Western Pacific region was experiencing an outbreak, and that outbreak has been controlled or waned in some places, but we continue to see cases and reemergences. However, overall, that curve is not really declining. We're continuing to see a steady circulation of monkeypox virus around the world. What I wanted to show you here is that we do have all the data from all the regions of laboratory confirmed cases, and the classic picture of the nice epicurve and the controlled and the downward sweep is seen in all regions except one. I think we can guess which that region is. So in your top left, we have the African region. So this is still just laboratory confirmed cases here, but even though it's laboratory confirmed cases, we are seeing that there was a participation in the global outbreak with an upswing of the epicurve, but we're also seeing what looks like a leveling off, and now an increase again. So part of that may be due to surveillance, yes, but improving surveillance, which is a good thing, but part of it would be actual due to increasing transmission of mpox in the African region, which is home to both clades. Clade 2 that went around the world and Clade 1, previously known as the Central African clade. So this is very concerning. We're not seeing the same trajectory of the outbreak in this region as we saw in the other regions. At the bottom, and I'm sorry for the overlap there, is not so great, just to illustrate the case fatality ratios and the difference between the regions. So the European region, overall, the case fatality ratio since 2022 has been 0.03%. In the African region, in contrast, even among these confirmed cases, it's been 0.9%, so 1%. So we're seeing an order of magnitude difference in the proportion of cases that lead to death in the African region. And so this is a public health issue for several reasons: number of cases, as well as burden of disease and burden of disease that leads to death, especially in young children, as we'll be seeing later. So others will pick up on the epidemiology from here, and I'm going to just take you briefly through some of the directions that we've received from the IHR, International Health Regulations Emergency Committee at the global level, which was convened. And then the Public Health Emergency of International Concern was declared by our Director General. It was in place for from July of 2022 through to May of 2023. And there were many meetings and discussions. And then after the Public Health Emergency of International Concern was lifted, the next step was what's called an IHR Review Committee. And the IHR Review Committee, with experts from around the world, determined that although the Public Health Emergency of International Concern had been lifted, it was critically important to maintain awareness, vigilance, and effort on mpox control in all regions and in all circumstances. And so the advice given to the DG was to issue standing recommendations for mpox, and that is in fact what happened. So throughout the declared public health emergency of international concern, countries' response efforts were guided by these temporary recommendations. And now, as the control and perhaps even elimination phase unfolds, countries' preparedness and response actions should be guided by the standing recommendations set forth under the international health regulations. These are available online on the WHO website, in English, French, I believe in all UN languages, so you should be able to find them there. And what we have here is just a summary. So the main point was that using IHR language, states parties, meaning member states, were recommended to do work in the following areas. One is that each country, wherever, in all regions, should develop a national mpox response plan or preparedness plan, depending on their circumstance, and integrate that plan into broader health systems. In other words, it's not meant to be a standalone program, but considerations around mpox preparedness, prevention, control, and response should be integrated in all levels of the health system. To strengthen and sustain testing and surveillance capacity and ensure that new cases of mpox were notified nationally and to the WHO. We've seen a drop-off in surveillance. So part of that downward curve is that countries have stopped reporting. Many countries are still reporting, thankfully, but some countries have stopped. In the African region, it's a bit mixed. Few countries are reporting, many reported for a while and stopped. We are encouraging you all to continue reporting your cases up to the national level and through the national level to WHO. States parties or member states are also advised to protect communities through ongoing communication, risk communication and engagement, and continue to build trust and fight stigma and discrimination. You may recall that the global outbreak affected mostly men who have sex with men. However, mpox can affect anyone. It's a disease that transmits through close contact. And in the African region, we have outbreaks due to close contact, outbreaks due to zoonotic spillover, and outbreaks due to sexual transmission among sex workers and also among other key populations. So stigma becomes an important factor that needs to be addressed, and trust needs to be built between health authorities and communities. And this goes for all different modes of transmission and all different populations. It's also critically important to invest in research to better understand mpox disease and transmission patterns and to develop improved vaccines, tests, and treatments. We'll come back to this during the whole series of these webinars over time. To provide travelers with information. As you know, disease travels with the traveler. Infections travel in boats and planes and trains, and travelers may be at risk for different reasons, because they're going to endemic areas where they may have close contact, because they're working in mining areas with lots of movement of populations and they may encounter, have encounters with sex workers, or because they're traveling to events around the world and they may have other close contact in large-scale activities or small-scale activities. Travelers have the right to be informed of the risks to which they expose themselves or are exposed. However, it is not recommended to put in specific controls at border points. This is not a strategy that WHO is advising. Really just information for travelers and cross-border collaboration, but not border controls. It's important to deliver optimal clinical care for patients integrated within primary care programs, as well as HIV and STI programs, with access to treatments and measures to protect health workers as well and caregivers. And to work towards equitable access to safe, effective, and quality assured tests, vaccines, and therapeutics treatments for mpox. So these are the standing recommendations that our Director General has issued to all WHO member states. And we hope to see these elements reflected in national mpox response plans. This is just a repeat of what the DG has said in the preamble. States parties are recommended to develop and implement national mpox plans that build on WHO strategic and technical guidance, outlining critical actions to sustain control of mpox. And where feasible, and it's context specific, achieve elimination of human-to-human transmission in all contexts through coordinated and integrated policies, programs, and services. So what does our framework actually look like? It should be published in the coming days, but there is a goal, which is to achieve control and sustain elimination of human-to-human transmission. We're acknowledging that this is also a zoonotic disease, but a zoonotic spillover event leads to secondary cases and community transmission. So we can stop the zoonotic transmission if we know more about it and have ways to do that, but we can also stop human-to-human transmission. So really dissecting these into different elements is really important to be able to understand what control strategies we can put in place. So the specific objectives of the framework are to achieve control of mpox outbreaks in every context, to advance mpox research and access to countermeasures, because these are critical, and to minimize zoonotic transmission of mpox. The key consideration is that the goal and objectives apply for all countries and contexts for different modes of transmission, but the way it's approached may be different, of course, in different contexts. The priorities for implementation are that there should be coordinated planning for sustainable long-term action. This is not a problem that's going to go away in a few days, and coordination of all the different actors is absolutely essential. And that's true in ministries of health as well as at local level and between partners at different levels. Secondly, integration in the yellow, integration of mpox consideration and activities into relevant health, laboratory, and community-based programs. Integration of services will achieve effectiveness and efficiency and sustainability in the delivery of response measures. And finally, strengthening global coordination and global support for implementation of mpox plans, which is what we are endeavoring to do as well. The strategic framework has, of course, an overall approach and guiding principles. As I've mentioned also already, it's absolutely critical to communicate, to collaborate with each other, and to integrate where possible. The best approach is to know your own epidemic. This echoes what the messages we learned through HIV/AIDS control over many years, but basically the epidemic may be different, not only at the national level, not only at the province level, but even at the local level. Understanding your own epidemic, understanding the risks, understanding the community and how they interact with those risks. And that's true for rural areas as well as for sexual transmission. Know your own needs. What are your gaps? What it is that you're missing? And then take action in accordance with all of these things. The guiding principles that we continue to maintain and have maintained throughout the global response is community leadership. Communities know what they need and are able to provide that leadership, and to advise also public health authorities. Equity and human rights are central to this particular framework, as most frameworks from WHO, and context-specific collaboration and integration I've mentioned several times. We also need a commitment to continuous learning. And the reason for that is that in this particular disease and infection, there's so many things we don't know. And you'll hear that in the presentations coming up from my colleagues. So these are just some examples of how we go about doing some of these things. So the framework is based on the 5 C's of collaborative surveillance, community protection, emergency coordination, scalable, safe and scalable clinical care, and access to countermeasures. And in addition to that, we have the overriding necessity to better understand the situation and to do research. So in the framework, you'll find that for each component of the 5 C's of health emergency preparedness and response, you'll find some suggestions of where you might want to consider integrating mpox thinking with other programs, whether it be in emergency operations, drafting of funding proposals, working with other key actors that don't normally participate in emergency response. In collaborative surveillance, for every country should have mpox as a notifiable disease, using integrated disease surveillance and response mechanisms, and so on. For community awareness, it's obviously important to distinguish between community transmission in a rural setting versus sexual transmission in a different setting. These are all ways in which we can tackle this challenge in ways that are appropriate locally and for the epidemiology to local operate. Again, for clinical care, achieving effective, holistic, optimal medical and psychosocial care is important for this disease, because the stigma is not only for the population groups that I mentioned before, but also for anyone that has a disease, an infection on their face, with lesions on their face, feel stigmatized, feel that they can't go out, feel that it will affect their standing in the community. And so an infectious disease that leads to skin lesions of any kind leads to challenges for psychological and mental health as well. Access and countermeasures and research I've mentioned already. So this is just to illustrate that this is a global disease now. We have outbreaks in Europe, North America, Asia, and Africa. And we have community transmission and we have sexual transmission. So it's complex, but each and every element of it does have some proposed solutions that can be tackled if we work together. This is just an illustrative time frame. I won't go through this now, but again, the 5 C's plus research and development, and over time, there are a number of things that can be done to move forward with one goal in mind, which is enhanced control of outbreaks wherever they are, and achievement of elimination of human-to-human transmission wherever that is possible. There will, of course, need to be some monitoring and evaluation of this overall approach over the next few years. And so you may find that you're invited to participate in some national program surveys once or twice a year. We'll be inviting all colleagues working in integrated disease surveillance to propose specific surveillance quality indicators, such as timeliness, lab processing time, all the ones that you're very familiar with for polio, measles, yellow fever, and all the others. So just take the same thinking and see how you can adapt it to mpox in your setting. Outbreak performance indicators, the proportion of suspected cases that are tested, the timeliness of case confirmation and outbreak response. There's a 717 approach some of you may be familiar with. And of course, quality case investigation, contact tracing, and follow-up. And then progress towards elimination, it will be, again, context specific, but proportions of numbers of regions or countries that have plans, and the mode that they find themselves in. And of course, absence of viral material in wastewater surveillance is yet another innovation that is being discussed now by interested parties at various levels. So I think that's my last slide. And I'm going to hand it back to the moderators. I'm happy to take any questions or discussion. Merci à vous tous pour votre attention.
Okay, thank you very much, Dr. Rosamond Lewis. This was a great presentation. Mohamed, we do have few questions. Maybe we can take that one unless Dr. Rosamond is leaving quickly. Otherwise, we can take those questions and at the end. How that sounds to you, Dr.
J'ai encore le temps. I think I have to leave at past.
Okay. So you got time. Yeah. Okay.
I won't be able to stay till the very end, but I can stay a while longer.
Okay. What I would suggest, and if you look at the question and answer, there was a question about, in Portuguese, the source of fonte de contaminação de variola de macaco pelo contacto ou alimento, ce qui veut dire, en fait, pour la contamination, ils veulent savoir la voie de contamination. Donc, vous pouvez expliquer ça. Et puis, the other question is in English. What is the percentage of member states known to have had registered mpox cases in the past that have updated the national plan and a reporting system as well? Probably you can address those questions while we are moving to the next presentation. Probably the answer will come as well, but it is always good to give the answer in the chat box. Okay, thank you very much. Colleague, just post your question as we go. You want to answer so we can move on? Or
sure, yes, I can take those quickly. Yeah. For the modes of transmission, I have mentioned them, but also I believe the next presentation is going to go over that in some more detail, the next two presentations. Very briefly, there is zoonotic transmission, which is from animal to human, and there are different modes of human to human transmission, mostly related to close contact, but I do want to highlight specifically the issue of person-to-person indirect transmission through fomites, bedding, towels, sheets, clothes, materials that are contaminated can also be infectious. We seem to have lost audio in English for some people. Perhaps, I'm not sure. Regarding countries, as I mentioned, 117 countries have reported confirmed cases during the global outbreak. Most of those are now only reporting sporadically, except in a few places where the number of cases seems to be rising again. Back to the moderators, there may be a sound issue.
No, it was good from my side here to hear you. Okay, this is a very good answer. And as you mentioned, the bed sheet, I think that's where the problem is. For example, those who have mice, rat in houses, and you know, when these materials are infected, it is possible that reverse can be as well from human to animal and so. But I don't have data on it. But that was one of the questions I in the previous webinar as well. So we have a lot to learn. And by learning as well on mpox, it will help to address other disease of zoonotic sources or even in non-zoonotic sources. Okay, we can move to the next. Thank you very much, Rosamond, but you can stay with us, please. I know there are more questions to come. Okay, we can move to the next presentation. You have 30 minutes. Dr. Michel Muteba. Over to you, please.
Okay, thank you very much, Dr. Tieble. So before I start, I'm just going to quickly run a very, very short animated video. And I hope
You can go ahead, Dr. Muteba. We can see and hear the video.
Hello, everyone. Quiet down, please. I have an announcement to make. As you may know, there's been a lot of talk about people falling ill in neighboring communities in the past few weeks. You see, there have been several reports of monkeypox infection around the region, making our work here all the more important. With this in mind, we have decided to invite a number of guest presenters to help you get a better understanding of monkeypox. Remember, awareness is key. Now, I am not an expert on monkeypox, but I can give you a short introduction nevertheless. Let's start then, shall we? Monkeypox is a contagious disease caused by a virus. This virus is dangerous to both animals and humans, but don't let the name fool you. Surprising as it may sound, monkeys are not the most important source of monkeypox, so we may have to look elsewhere to find the natural hosts of the disease. And believe me, candidates are plenty. Now, what we do know is that the animals which carry the monkeypox virus mostly inhabit tropical rainforests, so countries like ours are especially at risk. Couple this then with other environmental and social factors in our region, and we have ourselves a real problem, and so do other countries. After all, persons infected with monkeypox have been known to carry the virus to other places. I don't mean to scare you, of course. There are all sorts of things that we can do to keep ourselves, our families, and the community from getting sick, while experts and specialists are working tirelessly together to keep us safe and well informed. Thank you for coming. Enjoy the course and see you next time.
right. Thank you very much for this opportunity, and dear colleagues, dear participants. This short video that you just viewed now is available, and it's just to share with you that there is a platform that WHO has made available to everyone who's interested. It's called Open WHO, where you can have a course or some lessons on mpox, the response, the management, and how to control it. It's available online and it's free of charge. And that's where you can get a certificate, because I saw some participants are asking a question if they are going to get a certificate after this webinar. So the certificates are available. We are just going to share with you. We are going to share with you a link on for the Open WHO lesson on modules on mpox, and you can get a certificate there. So I'm just going quickly now to share my presentation with you for to look at the to introduce. Okay, to introduce you on to give you an overview of the mpox the monkeypox virus, the taxonomy, and talk a bit about the genome structure. My name is Dr. Michel Muteba. I am a senior epidemiologist standing in the hub of Nairobi for WHO Regional Office as an IDSR and AP strengthening consultant or focal point. So today, colleagues, I'm going to take you quickly, give you an introduction on mpox, thanks to Dr. Rosamund, who already gave us a very good introduction and epidemiological overview for what is happening globally on mpox. I'm just going to continue and talk about the taxonomy of monkeypox virus, talk also about the genome structure of monkeypox virus, before taking you to just a short comparison with other pox viruses. So what I want you to remember today is mpox, which was formerly called monkeypox, is an infectious viral illness caused by the monkeypox virus, which can occur in humans and a wide range of other animals. So it was first identified in a laboratory in Denmark in 1958. So that's where there was someone who was doing a test, or was just looking at monkeys, and I'm going to give you a bit more details about that, but it was in a laboratory in Denmark where it was discovered for the first time. And that's why it was called monkeypox. But the first human case was reported in 1970 in the DRC. At that time, it was called Zaire. And since then, we had sporadic cases and outbreaks that have been reported in several African countries. And mpox is caused by, as I said, the monkeypox virus, which belongs to the orthopox virus genus, the same genus as the virus that caused smallpox. So what we have just to remember that mpox is not as severe, or it's less severe than smallpox with a low fatality rate, but it's transmitted primarily from animals to humans. And here we'll talk also about, the animals that are suspected to transmit this, as who could be maybe the reservoir. So it's geographically found in the Central and West Africa, as you saw in that short video, near tropical rainforest. It's considered as a zoonotic disease with outbreaks that are often occurring in rural areas near wildlife. So just briefly on the clinical presentation of mpox, because here, remember that when we are talking, we are not just sharing this with people who are expert in health, but we also want to give an opportunity to people who are not specialists in health to also understand a bit about the clinical presentation of mpox. But we have colleagues who will come in the future weeks, to talk more about this. So the clinical presentation of mpox is similar to that of smallpox. So it starts with fever, headache, muscles ache, and general feeling of discomfort. And this is followed by a rash that progresses to papules, vesicles, pustules, and crust. So most cases of mpox are mild and self-limiting, but severe cases can occur, especially in immunocompromised individuals. So you can see on the picture here, where we have someone who contracted mpox. But here, this is a case of with a complication, because this person did not know that he was HIV positive, and he was definitely immunosuppressed. And that's why it's complicated to lead to what you see here on his nose. But this is also a case of mpox. So what I want just to say here, it's overall, mpox remains a concern in parts of Africa, but also in the world. And it's very important, just as Dr. Rosamund has shared with you, it's very important to understand its history, to understand the transmission, to know the clinical presentation, and it's also very important, to know how to effectively do the surveillance, the prevention, and the control efforts. Now, let's just go to the history of this virus that now has become it has been in the news since 2022. So there was someone called Alexander von Magnus, Preben Christian, who you see here on this picture. So he's a Danish physician virologist. So while he was investigating monkeypox or mpox disease in 1958, that's when he discovered that there was an epidemic that happened in his laboratory, or in a laboratory in Denmark, where monkeys from the colonies that is called Cynomolgus, it's revealed that the mpox virus, or the monkeypox virus, was from the phylogenus coming from the West African clade. And so, as I said, this guy was well known for his research on influenza, polio vaccination, and of course, on his research on monkeypox. He was from the University of Copenhagen. So what I want you to remember here, that the first known case of human mpox was discovered in the DRC, Congo, on a 9-month-old child who was admitted for suspected smallpox to the Basankusu Hospital in Zaire, or the Republic of Congo then. And you can see at that time, these were articles that were written on what was discovered, a human infection caused by monkeypox virus in Basankusu territory, Democratic Republic of the Congo. So this was written in 1972. Okay. So this child had a rash that lasted 2 weeks. He recovered, the child recovered, and just when he was about to be discharged, in October, he developed measles, unfortunately, and died 6 days later. And what we know about that child, that he was never vaccinated. He did not receive any vaccine against smallpox at that time. And at that time, no other family members or neighbor presented with pox-like rash. So a team went down there to do an investigation to see if they could find animals that would have transmitted that disease or that virus to the child. So 25 different animals, but also 40 monkeys were examined, and samples were taken at that time to the WHO smallpox reference laboratory in Moscow, in Russia. But there was no monkeypox virus that was identified. So this is what I can tell you about the history, but now let's go a bit to the timeline of mpox virus related events. So 3,500 years ago, researchers and scientists have suspected there was a separation of mpox virus within the old world of orthopox viruses that took place. And this is called, the orthopoxus virus molecular evolution study. It's available online. I think when we share with you this presentation, there's some references that you can refer to. So 600 years ago, it is believed that that's when the monkeypox West African subtype appeared. And in 1899, there was an mpox virus that was identified in 5 species of African rope squirrel that were collected across Central Africa. Please remember, if you ask me questions about how do we know this, remember that in terms of innovation and technology, there are now very good methods that could just analyze DNAs, even that could date from 2,000 years ago. And as I said, in 1958, that's when the first mpox virus was identified in Denmark. This was following an outbreak of the pustular disease in monkey colonies that were imported from Singapore. Please note that those monkeys were imported from Singapore and not from Africa. Now, from 1959 to 1964, mpox virus, which was reported among colonies of captive monkeys, were also described in the USA, in America, but also in the Rotterdam Zoo in the Netherlands in 1964. In 1970, the first human monkeypox case was identified in Congo. I've spoken about that. And in 1971 and 1972, there was an mpox outbreaks that occurred in Cameroon, Nigeria, and Liberia. In 1978, from 1978 to 1986, there were mpox outbreaks that were reported in several African countries, including Cote d'Ivoire, Sierra Leone, and the Central African Republic. And in 1980, the routine smallpox vaccination was stopped because it was declared to have been eradicated by the WHO. Now, after that, over 15 years after they stopped the smallpox vaccination, in 1996 to 1997, there was a major outbreak of human mpox that occurred in DRC, again, in Katakokombe. And there were at least 73% of the cases that reported to have had contact with another human case, while only 27% of the cases, in total it was 89 cases, reported to have been in contact with a wild animal. Now, in 2003, that was the first time that a human mpox outbreak occurred in the US, where more than 71 infected people were identified. And these were actually due to rodents imported from Ghana that were sold as exotic pets and that have been transmitted by prairie dogs. In 2017, that's when we had the largest West African mpox outbreak that began in September 2017 in Nigeria. And this followed a very heavy rainfall and flooding in the country. So by September 2029, I think it lasted two years, at least 176 cases of human monkeypox were confirmed from 18 states in Nigeria. In 2018, 4 individuals that were traveling from Nigeria to the UK became the first human mpox cases exported from Africa to Europe. And in 2019, there was a case of human mpox that was confirmed in the UK that, again, was suspected to be imported from Nigeria, where there was a Nigerian traveling to Singapore for a training course who developed skin lesion shortly after arrival, and he was diagnosed with human mpox. In 2021, there were cases of mpox that were reported in the UK, Israel, Singapore, and all were linked to trips from Nigeria. Not that they were Nigerians, but they were probably other citizens of the world. Now, I know currently we are under this outbreak that started in 2022. It was a global outbreak because in May 2022, there was an mpox outbreak outside Africa. It started actually from the UK, and then it spread to Portugal, Spain, and other countries, actually leading to over 117 countries that reported about 94,000 cases, and unfortunately 181 fatalities. So in July 2022, mpox was declared as the public health emergency of international concern by the World Health Organization. Now, in November 2022, WHO has recommended the using of the name mpox as a new name instead of monkeypox, and this was due to stigmatization and racist comments on the social media when referring to monkeypox. But please remember that even when we are talking about mpox, but the virus still keeps the name monkeypox. In May 2023, the mpox stopped being a public health emergency of international concern because cases were declining and declining, but we still remain with some issues in the DRC particularly, but in the African region. So now, let me just focus quickly only on the mpox virus so that I can share with you what we know so far about its characteristics. So the monkeypox virus, which is usually abbreviated by MPXV, is the double-stranded DNA zoonotic virus belonging to the orthopox virus genus, which also includes the variola virus, which caused the smallpox virus. It also includes the vaccinia virus. The vaccinia virus is actually used to make the smallpox vaccine, and also the cowpox that you might all know. And in terms of its morphology, it has a brick-shaped morphology. It's usually oval, and it's enveloped by a lipid membrane, and it is approximately 200 nanometers in size, and making it larger than many other viruses. And talking about the genome of the mpox virus is the monkeypox virus is relatively large, consisting of approximately 200,000 base pairs, and it encodes for a variety of proteins that are involved in virus replication, host immune evasion, and virulence. So all these actually, when you can look at the picture, that are colorized the electron microscopic image, they actually give you a picture of the monkeypox virion that was obtained from a clinical sample associated with the 2003 prairie dog outbreak in the US. So the picture that you see here depicts a thin section of from a human skin sample. And on the left here, we have the mature oval-shaped virus particles. And on the right, you can see that we have the crescent and spherical particles of immature virions. And these pictures were obtained from CDC. Now, let's just talk about the taxonomy of the monkeypox virus. So maybe I should spare you of these scientific names, but it's just good for you to know that the family of the Poxviridae, the pox virus, is subdivided, and this is based on the animal host, into two subfamilies. Okay, we have what we call the Cordopoxvirinae and the Antomopoxvirinae. So the first family is known to infect vertebrates, and it can be differentiated into 18 genera. So, and this will include the orthopox virus. While the other family, okay, is known just to infect in invertebrates, and it's usually grouped into 4 genera. So the realm, as I said, it's usually the Varidnaviria, but I think we can skip in terms of kingdom or domains. I think usually sometimes for viruses, we don't talk about them. But when you start that from the family, you can see that it's the Poxviridae, and then it goes to the genus of the orthopox virus, and the species is the monkeypox virus. So this is kind of important for biologists or virologists actually to know. Yeah, so why is it important to know this? And that's why we are showing you this family tree of the Poxviridae family. It's to show you the two subfamilies. And this is where we get our monkeypox virus, okay, which is important to know. And they are they're in the same group with the cowpox virus and also the variola virus that was responsible for smallpox, ou variole in French. Now, looking at the monkeypox virus genome, I just want you to remember, because we usually talk about the clades, two clades of monkeypox. So it's important for you to know that there are two different clades in what we have seen so far in the transmission of mpox. So the clade 1, which is called also the Congo Basin clade, is usually seen in the Central and East Africa, and it's usually more serious, cause more serious, and it's more severe than the clade 2. And even the actual outbreak that we see in the DRC is mostly due to clade 1. Clade 2 is what is called the West African type of monkeypox virus. It is usually seen in the West Africa and other countries affected by the global mpox outbreak, and it usually causes milder diseases. And under clade 2, we have clade 2A and clade 2B, but it's can continue under A. You can have A1, A2, A3, A4, depending of sublineages. Okay, so we can have A1, A2, B1, B2, but what I want you just to remember is clade 1 is associated to high morbidity, death, and human-to-human transmission, and the viremia is usually very high. While it's important to know this, it has also shown a higher fatality rate, usually 10%, than the West African clades. So you can see on the map on the right here, the countries that have been affected by different types of clades from 2022 to 2023. So you can see in blue, it's clade 2B. And you can see here in gray, we have clade 2B, but also cases of clade 1 that have been identified there. But in red, that's where you see, especially in the central part of Africa, it's clade 1. So when you look at the picture on your right here, it gives you an idea of the structure and genome of monkeypox virus. So which usually contains 5 distinct structures, and it includes what we call the core, the palisade layer, the outer and inner members. And we also have the surface tubules and the nucleic acid. And in the case of monkeypox, it's the DNA. So the monkeypox genome is usually comprised of 2 variable regions and a large conserved central genomic region, okay? And an inverted terminal repeats, which we called ITR, which is located in the variable region. And it's this one which consists of some hairpin loops and short-term, short tandem repeats. So the 10 kilobase inverted terminal repeats locate at both ends of the genome. So this is what I want you to know, because now when we start going into genomic sequencing, so we look at this, that the sequencing is done to see the difference between this virus and what are the mutations that usually appear when we look at these elements. Okay. So now I want you to understand something here. The differences in virulence stem from the variabilities in the genome organization. caused by deleted gene regions and the gene fragmentation in open reading frames. So that's why, when we do sample collections from different areas or different individuals, and clades, it's really vital to determine the genetic properties of the mpox virus. And this will help a lot, in terms of research, in terms of finding where is this one coming from, and what are the differences that appear, or even in terms of the severity of the disease. It's very important that to have this. So there is a lot. There is a lot of references that I've attached to this slide for those who want to study more. There is a lot that has been actually published, but remember that there is still research that needs to be done actually on this virus. So so there are some key features that I just want quickly before we end this presentation to share with you. So all these features and genes that are important for the replication of the mpox, the monkeypox virus, they also explain, they explain not only the replication but also the mutations and what happens in the host human system. So you look at the gene organization. There is a central region. I've spoken about it. Okay, with conserved replication and virulence flanked by variable regions. So some of the factors that are also features of the mpox virus, they determine the host immune response, and they also inhibit what we call apoptosis. So because we have to round up because of time, I just want to talk quickly about the evolution of the mpox virus, the monkeypox virus genome. So we just need to understand that the evolution, there is a rate when it comes to mutations, which is usually between 10 or 1 divided by 100,000 to 1 million in terms of replication rate. And this is just per replication site. And this you can see from the, this explains why from the outbreak or the monkeypox viruses that were identified in 2003 in the US to those that we see now in 2022 and 2023, there is a big difference. There is a big difference because a lot of mutations have occurred. There is also a recombination that happens, and this is due usually to the selection pressure and what we talk about the genomic stability of the virus itself. So we can expect in the future to see even more and more mutations, replications of this virus. This is just an example of the differences between when we do genomic sequencing between the genomes of the monkeypox virus and the variola virus of the smallpox and other poxes. So here you can see, let me just focus in terms of differences, that from different families. But smallpox virus usually has host the humans, but while the cowpox is usually in animals, but it can also infect humans. But the monkeypox virus is in animals, but also can infect humans or infect humans as well. And the chickenpox virus has host as humans. So in terms of clinical presentation, the smallpox virus is usually severe and has potential to be fatal, fever and distinctive skin lesions, while for monkeypox, I think it's less fatal. In terms of eradication, smallpox has been eradicated through vaccination and public health measures. Cowpox and monkeypox viruses are still circulating and are sporadic in human cases, while chickenpox is common and vaccination reduces actually its incidence and severity. So I think let me stop here to allow some session for question and answers. Be happy to take them. Over. Thank you, Chair.
Okay, thank you very much. Hello?
Yes, yes.
Okay, I say thank you very much, Dr. Muteba. And this is a great presentation. I think you went to the historic, to the genome structure and the different clade we see. And really, it is fantastic presentation. And Dr. Daniel, for questions, and because this is interactive now, we can see a lot of hand clapping. So that means the presentation was very rich, and the presentation done by Dr. Rosamond as well. And there are a few questions which we try to pick some of these questions. Well, that one is, okay. One question I can just read it to you. What are the plans to roll out more training and retraining to and training to subnational and local community information informant? And because the participant think that every case count, and they come from a community. That's the exact phrase, I repeat. And then there is a need to focus more attention on capacity building to the people at the grassroots, because outbreaks start at community level. And that's not a really question. It is a part of contribution. But if you could just look at the training aspect of what you just cover, in particular, the cellular aspect, the infection, zoonotic sources, and the different clade, the case fatality, and how to build the capacity at community level to be able to control or to eliminate this disease. If you look carefully, and you know, mpox, as you outline, it has been detected through community strengthening, because if you look back at the history, it was said that every person who will come up with, who will detect a smallpox, and I think it was $90 US dollar. If you look carefully, then the surveillance was very strong at that time. And that's why it come to the attention. Then if we continue, we had to continue to that, probably we will not reach what we experience now, because surveillance is a key for disease control. And those papers you just presented as well, it was clearly written, WHO recommendation to carry on to strengthen surveillance. In case there is, then we need to think about vaccination. Yeah, so you can just probably, because it is interactive, and then I will recommend, encourage a colleague and to just fire the question or think they would like to know more about the genome structure and the even vaccine if you want to, or otherwise we can move to the next presentation. You will have plenty of time to ask clarification. Over to you, Daniel, if that sounds good.
If you allow me.
Yes, please.
Yes, thank you, Dr. Tieble. Very, very interesting submissions from Dr. Mitchell, and I want to thank you again for this interesting deep dive into this area. Thank you so much. Yes, it is good for us to move to the next presentation because they are correlated. Then participants, please keep posting your questions. We are taking note of them. We are harvesting them and even archiving them for further deep dive. We can go into the top presentation. Then, since the top presentation also will engage the Dr. Mitchell, then definitely they will answer the questions together. Dr. Atiable, please, we can move on to the next presentation. Thank you so much. And thank you, Dr. Mitchell, once again.
Before that, please, just want to say to interpreter Gnima, please give the floor to another interpreter. You're still experiencing many internet issue and Francophone are complaining. Please give the hand to another Francophone interpreter. Thank you. Over to you.
Mohamed, and so we will, Dr. Michel Muteba, we will be with you again. You're not going far. And with Dr. Diallo, Mamadou Diallo, you are going to present about the epidemiology and transmission, one of the exciting parts. And so you're going to present that one so we can understand the outbreak, the reservoir host, the mode of transmission, and the risk factor, and why the disease is continue in the community. Yeah, over to you, please.
Okay, thank you very much, Dr. Chible. Good morning, good afternoon, colleagues. I see that the French translation is bad for someone, so I will talk in French. As you can see, slides are in English, so I will talk in French. Please, Dr. Muteba, can you allow me to share my screen from here, please? Thanks.
Slide mode, please.
Is it okay?
Yes, it is.
OK, thank you very much. OK, donc, je m'appelle Salou Diallo, je suis épidémiologiste biostatisticien au sein du bureau régional de l'OMS Afro, basé à Dakar ici. Et je vais faire cette présentation avec mon collègue Michel, qui vient de vous présenter, donc, de vous faire une brève présentation du virus. Nous allons, je vais commencer par présenter très brièvement ce que nous allons aborder dans cette présentation. D'abord, nous allons faire une petite introduction sur le mpox. On ne va pas revenir sur tout ce que Dr. Michel a déjà parlé avec vous. Nous allons continuer par faire une description de l'épidémiologie, donc des épidémies de mpox qui ont survenu, et particulièrement la dernière qui est toujours en cours. Et donc, dans ce sens, nous allons parler de la répartition mondiale et du contexte historique, ainsi que des épidémies et des régions qui en sont touchées. Ensuite, nous allons aborder les réservoirs hôtes de mpox. Quels sont les réservoirs potentiels et quel est leur rôle dans le maintien donc, du virus dans la nature. Nous allons aussi parler des modes de transmission de mpox, donc que ce soit la transmission interhumaine ou bien la transmission entre la faune sauvage et l'homme, ainsi que les facteurs qui influencent cette dynamique de transmission. Et enfin, nous allons parler des risques facteurs, donc des facteurs de risque des épidémies de mpox. Alors, à la fin de cette séance, nous voudrions que vous soyez en mesure de comprendre l'épidémiologie du mpox, sa distribution mondiale, son contexte historique, ainsi que les récentes épidémies, identifier les autres réservoirs de mpox et pouvoir comprendre le rôle dans la transmission du virus mpox, décrire les différents modes de transmission de mpox et en faire reconnaître les facteurs de risque associés aux épidémies. Alors, sans plus tarder, Dr. Michel vous a déjà parlé du mpox. Donc, c'est une maladie virale qui provoque une maladie qui est semblable à la variole qu'on a connue par le passé et qui a été éradiquée depuis. Et comme il l'a dit, la maladie a été identifiée pour la première fois en 1958 chez un singe, d'où son nom, bien évidemment. Mais depuis lors, il y a eu beaucoup de cas humains qui ont été documentés, notamment depuis les années 1970. Et en ce qui concerne les symptômes, comme vous pouvez voir au niveau des images à votre droite ici, on note notamment des éruptions cutanées, des fièvres, des courbatures et des douleurs musculaires. Mais la plupart des personnes qui sont contaminées se rétablissent entre 2 à 4 semaines si des soins appropriés sont dispensés à ces personnes. Maintenant, concernant les épidémies, contrairement à la variole donc, qui a été éradiquée, les épidémies de mpox, particulièrement avec cette souche-là, est encore endémique dans certaines régions de l'Afrique centrale, avec des cas sporadiques que nous observons qui surviennent par-ci, par-là. De temps en temps, nous allons voir tout de suite. Et avec la récente épidémie qui a été déclarée depuis 2022 et qui s'est produite principalement, mais pas exclusivement, parmi les hommes ayant des rapports sexuels avec des hommes, on note par exemple que les clades 1 ainsi que les clades 2 peuvent être transmises de façon sexuelle. Alors, l'historique des épidémies, je pense que là aussi, on ne va pas trop s'attarder là-dessus parce que Dr Michel en a déjà longuement parlé. Ce qu'il faut retenir ici, c'est que depuis la première épidémie qui a eu lieu donc en 1970, régulièrement, on a des épidémies qui surviennent un peu partout. En 2003, on a parlé donc de l'épidémie qui a eu lieu aux États-Unis, qui était liée à un cas importé. Et depuis 2005, ce qu'on note particulièrement pour la RDC, c'est que des milliers de cas sont rapportés chaque année, même si l'épidémie en question n'avait pas retenu l'attention du monde entier, comme cela a été le cas depuis 2022, avec notamment son expansion dans les autres pays. Et en 2017, là aussi, on a parlé de l'épidémie qui a eu lieu particulièrement au Nigeria, avec 176 cas qui ont été confirmés provenant de 18 États. Et donc, depuis 2022, il y a eu cette grande épidémie que nous avons connue et qui a dépassé les frontières africaines pour aller vers tous les autres continents ont été touchés par cette épidémie. Alors, avant 2022, on voit ici qu'il y avait quelques cas qui ont été notifiés, notamment aux États-Unis et dans la partie africaine, la région de l'Afrique de l'Ouest, ainsi que de l'Afrique centrale, mais avec quelques cas sporadiques. Et ces épidémies n'avaient pas retenu l'attention du monde entier. Mais à partir de 2022, vous pouvez le voir avec la carte à droite ici, il y a eu une expansion géographique des épidémies touchant tous les continents. 117 pays ont été touchés par cette épidémie depuis 2022. Dans ces 117 pays ont rapporté au moins un cas confirmé d'épidémie de mpox. Et au total, un peu plus de 94 000 cas ont été confirmés dans ces 117 pays, avec 181 décès qui ont été rapportés. Et on va voir tout de suite la répartition de ces cas dans ces différentes régions. Là, nous avons l'évolution de la courbe épidémiologique. Ce que nous constatons, c'est que depuis mai 2022, il y a une explosion, une évolution exponentielle des cas, comme c'est le cas pour la plupart des épidémies, avec une courbe qui ressemble quelque chose à cela, une courbe en cloche, avec une augmentation des cas dans un début, et suivi par un pic et puis une décroissance des cas au fil du temps. Mais bien évidemment, nous allons voir que cette évolution est différente d'une région à une autre. Ici, ce sont les régions de l'OMS qui correspondent à peu près au continent. Donc, cette épidémie, cette évolution, elle est différente d'un continent à un autre. Et depuis septembre 2023, où l'épidémie n'est plus considérée comme étant une urgence de santé publique de portée internationale, on continue quand même de notifier des cas. C'est pour ça qu'on préfère séparer cette partie-là pour montrer qu'il y a quand même quelque chose qui se passe. Il y a plus de 800 cas qui ont été rapportés, notamment en septembre 2022 et en septembre et en octobre 2023, et ainsi qu'en novembre 2023. Donc, des cas continuent d'être rapportés dans toutes les régions de l'OMS, telles que stratifiées, comme vous pouvez le voir ici. Et la tendance, elle est décroissante pour certaines régions. On peut voir, par exemple, dans la région du Pacifique Ouest, dans la région de l'Asie du Sud-Est, la tendance globale est à la baisse. Mais quand on regarde l'évolution globale, on constate qu'il y a plutôt une évolution en dents de scie, et avec une légère augmentation ici depuis janvier 2024. Ce qu'il faut noter, c'est que à partir du moment où l'épidémie, la grande épidémie, n'est plus considérée comme étant une urgence de santé publique de portée internationale, les systèmes de surveillance ne fonctionnent plus comme quand on était à la phase aiguë de la maladie. Donc, on peut avoir une sous-notification des cas ici qui est tout simplement due au fait que la surveillance est maintenant focus sur d'autres maladies que celle de mpox que nous avons connue. Alors, qu'est-ce qui se passe dans les différentes régions? On a vu qu'il y a une expansion géographique de l'épidémie dans tous les continents. Mais au niveau des cas de décès ainsi que de la létalité, on peut constater que pour les cas, par exemple, la région de l'Amérique a rapporté le plus de cas. 61 115 cas confirmés ont été rapportés dans cette région, ce qui représente 65% de tous les cas qui ont été rapportés depuis le début de cette épidémie de 2022. Suivi par la région de l'Europe avec 27 056 cas, ce qui représente 3% des cas qui ont été rapportés, la région du VPRO ainsi que dans la région de Afro. Pour la région de Afro, on constate qu'il y a 3% des cas qui ont été rapportés dans cette région et 12% des décès. Et là aussi, quand on regarde au niveau des décès, la région de l'Amérique comptabilise le plus grand nombre de décès rapportés avec 138 décès. Et au niveau des létalités, on constate que la région de MRO, avec 1,05% de létalité, est celle qui a la létalité la plus élevée, suivie par la région de l'Afro avec 0,81% et puis la région de WEPRO avec 0,28%. Mais je l'ai dit tantôt, depuis que cette épidémie n'est plus considérée comme une urgence de santé publique de portée internationale, les systèmes de surveillance ne sont plus comme pendant la phase aiguë. Mais même pendant la phase aiguë, ces continents n'ont pas les mêmes capacités en termes de surveillance, en termes d'accès aux soins de santé et les comorbidités en ce qui concerne, par exemple, le VIH, ainsi que le type de clade ne sont pas les mêmes dans les différents continents. Donc, un continent qui a ou une région ou un pays qui a un système de surveillance qui n'est pas très performant ne va pas notifier de cas comme un pays ou une région où le système de surveillance est très performant de la communauté jusqu'au niveau central. Il y a un système qui est mis en place pour pouvoir rapporter quasiment à temps réel les cas qui sont notifiés. Ce qui fait que ces chiffres que vous pouvez voir ici peuvent différer tout simplement parce que les systèmes de surveillance ne sont pas les mêmes. Mais cela étant, cela nous donne une indication de l'ampleur de l'épidémie dans ces différentes régions. Maintenant, si on regarde l'évolution des courbes épidémiologiques, le docteur Rosamond a fait état de ces courbes. Généralement, une courbe épidémique, elle évolue en cloche avec une augmentation exponentielle. On arrive à un pic et puis on arrive à une décroissance. Cela est observé quasiment dans toutes les régions, donc, sauf la région africaine où on constate que même si ici, il semblait y avoir cette tendance-là, après ça, la tendance elle est plutôt stable avec une évolution en dents de scie et depuis janvier 2024, une tendance à la hausse est observée, même si il y a beaucoup de pays qui ne rapportent plus comme avant. Pour le moment, il y a la RDC qui rapporte correctement et de façon régulière, suivi par le Libéria, mais d'autres pays qui sont affectés dans la région africaine ne rapportent plus. Mais malgré ça, on a cette évolution croissante des cas depuis janvier 2024. Ce qui n'est pas le cas justement pour les autres continents ou pour les autres régions où on constate une tendance à la baisse, notamment pour la région des Amériques. Il y a encore des cas qui sont notifiés, mais la tendance elle est globalement à la baisse. Pareil pour la région de l'Asie du Sud-Est, de la région du Western Pacifique, ainsi que la région européenne où d'ailleurs, depuis 2023, il y a vraiment très peu de cas qui sont rapportés. Alors, si on revient au niveau de l'Afrique, vous pouvez voir ici la carte qui montre les pays qui sont très touchés. Ce qui frappe quand on regarde cette carte, c'est le partage des frontières entre la plupart des pays qui sont touchés, notamment partant de l'Afrique de l'Ouest jusqu'en Afrique centrale avec la RDC qui rapporte le plus grand nombre de cas. Mais bien évidemment, ce n'est pas seulement cette bande qui est touchée. Il y a aussi cette bande-là avec l'Afrique du Sud, mais bien sûr avec juste 5 cas qui ont été rapportés, qui ont confirmé, le Mozambique avec juste 1 cas confirmé, mais aussi le Libéria avec 21 cas en Afrique de l'Ouest. Donc, c'est vraiment cette bande-là, cette région ou cette partie de l'Afrique qui est la plus touchée et pour laquelle les pays partagent des frontières communes. Si on vient au niveau des cas, donc le pays qui a rapporté le plus de cas depuis le début de cette épidémie, c'est la RDC avec 1605 cas à la date, bien sûr, du 29 février 2024. C'est 1605 cas rapportés par la RDC, ce qui représente 59% des cas et 9% de décès avec 2 décès qui ont été confirmés. Le Nigeria vient juste après avec 843 cas rapportés, ce qui représente 31%, puis le Ghana, puis le Cameroun. Donc, quand on regarde bien, on constate que la RDC, le Nigeria et le Ghana sont les pays qui ont rapporté, je préfère dire les pays qui ont rapporté le plus de cas que de dire que les pays qui sont les plus touchés, parce que les systèmes de surveillance ne sont pas les mêmes. Et on a vu en RDC depuis 2005, il y a des milliers de cas qui sont rapportés chaque année, donc ils connaissent c'est quoi la mpox. Ils ont établi un système pour pouvoir rapporter les cas. Cela peut expliquer, entre autres, pourquoi est-ce qu'on voit ici le plus grand nombre de cas qui est rapporté. Donc, pour les autres pays aussi, il y a quelques cas souvent importés qui ont été rapportés, même si ces pays ne continuent plus actuellement de rapporter. On a notamment le Congo où il y a actuellement aussi une épidémie qui est en cours avec des cas qui sont rapportés chaque mois, la Centrafrique, le Libéria aussi. Alors, si on vient au niveau de la désagrégation de ces cas, vous avez pu constater qu'en Afrique, il y a un total de 2717 cas qui ont été rapportés depuis le début de l'épidémie. Et parmi ces 2717, c'est seulement pour 672 cas qu'on a des informations détaillées en ce qui concerne la répartition par sexe, notamment par âge, ainsi que les autres informations. C'est pourquoi nous devons absolument renforcer les systèmes de surveillance pour qu'on puisse obtenir des données qui nous permettent de prendre des décisions. Parce que c'est seulement 25% des cas pour lesquels on a des informations détaillées. Si on n'a pas d'informations détaillées, ça va être très difficile de pouvoir prendre des décisions éclairées. Alors, une petite comparaison quand même si ces données ne sont pas avec leur faiblesse qui est que ça ne tient pas compte de tous les cas qui ont été confirmés. De façon globale, on a 96% des cas qui ont été rapportés qui sont des hommes, particulièrement des hommes ayant des rapports sexuels avec d'autres hommes qui représentent 85% des cas confirmés qui ont été rapportés dans tous les continents et pour lesquels on a des informations détaillées, avec un âge médian qui est de 34 ans. Mais si on vient dans la région africaine, au lieu de 96% des cas qui sont rapportés chez les hommes, on est à 53% qui sont des hommes et 47% qui sont des femmes. Et l'âge médian est de 17 ans. C'est pratiquement le double quand on vient au niveau global. Et parmi donc, la répartition, quand on regarde la répartition de l'âge ici, on voit que 50% des cas sont âgés de moins de 17 ans. Et parmi ceux-là, environ 18% sont âgés de 0 à 4 ans. Donc, la répartition globale des cas diffère vraiment entre la région africaine et les autres régions, ce qui est notamment illustré par ce graphique-là. Là, nous avons ce qu'on peut appeler la pyramide des âges pour tous les continents. Donc, pour tous les cas confirmés qui ont été rapportés à la date du 29 février, pour lesquels on a des informations détaillées selon l'âge et le sexe, on a ce graphique-là qui montre clairement que ce sont les hommes qui sont les plus touchés, donc comme je le disais, un peu plus de 96%. Et parmi eux, les tranches d'âge les plus touchées, c'est les tranches d'âge de 18 à 40 ans. Donc, ce sont les deux tranches d'âge qui sont les plus touchées au niveau mondial. Mais quand on vient au niveau africain, on voit que la pyramide des âges, elle est plus ou moins proportionnellement répartie entre les hommes et les femmes, je dirais équitablement répartie entre les hommes et les femmes. Et les tranches d'âge les plus touchées, ce sont les enfants ou les adolescents de moins de 17 ans, de 0 à 17 ans, avec notamment de 0 à 9 ans, et la tranche d'âge qui est la plus touchée, que ce soit chez les garçons, que ce soit chez les filles. Donc, c'est très important de faire cette distinction qui fait aussi que les stratégies que nous devons mettre en place doivent différer en fonction de la situation épidémiologique locale dans les pays africains. C'est pourquoi nous devons avoir un système de surveillance qui est performant pour ne pas tout le temps faire appel aux données ou aux stratégies qui sont prises au niveau global et vouloir les adapter dans notre contexte qui est différent. Et ces graphiques-là montrent clairement cette différence. Alors, je vais m'arrêter là et puis repasser la parole à mon collègue Dr Michel qui va maintenant vous parler de symptômes et des risques facteurs ainsi que des réservoirs hôtes de la maladie mpox. Merci pour votre attention.
OK, merci beaucoup, Dr Saliou. Alors, je vais continuer avec la présentation. Comme ça, tu me donnes la possibilité de pouvoir partager de ce côté. Et alors, je voulais aussi demander à l'équipe qui organise, parce que je vois qu'il y a beaucoup de questions sur d'autres sujets. Dr Thieble, il y a beaucoup de questions sur d'autres sujets qui seront développés dans les prochaines sessions, de notre webinaire, de notre séminaire. Je crois qu'il faudrait le communiquer aux participants parce qu'ils ont l'impression que c'est juste ça et puis c'est juste ça sur mpox et puis ça s'arrête là. Non, aujourd'hui, c'est juste l'introduction, mais je pense que le mardi prochain, il y aura d'autres sessions. Je pense que c'est mieux peut-être de leur montrer aussi l'agenda. Voilà. Alors, I'm trying just to share my screen quickly. And continue from where Dr. Saliu left the presentation. Okay, okay, colleagues and dear participants, something that I just want to add, especially on the DRC. I know we have presented to you the number of cases that have been reported so far in to WHO. And it seems like for the DRC, the numbers are not really, okay, they are underreported, but there is one reason to that that I want to mention. So you see, for example, from the beginning of this year, January 2024 up to Epi Week 14, which was like 2 weeks ago, the Democratic Republic of Congo has reported over 5,000 suspected cases. But you'll see that at a global level, we do not report suspected cases, but we report on confirmed cases. And unfortunately, out of those 5,133, if I remember quite well, 5,133 suspected cases, only 800 samples, above 873, if I remember well, where samples were collected from various patients and tested for mpox. And out of those, the positivity rate came back to around 67, almost 70%. So if we have to do an inference here, we'll probably find that out of those 5,133 suspected cases, we could have 3,000, more than 3,000 confirmed cases. We could have those ones. But now, because it was only 873 samples that were collected, and out of those, only 500 cases were confirmed. So what is reported globally, it's to say in the DRC for this particular period, we have around 500 cases from the beginning of this year. So you can see that we are missing almost 5 times more cases that could be identified and confirmed if there is a systematic testing, as it happens in countries like Nigeria, where every suspected case is tested. But of course, when we look at logistics and other challenges related to financial resources, we understand that it's not all tests that can be tested in the DRC. But I hope that with these activities that are going to be implemented, we'll have many test kits that are going to be made available in the DRC as well, so that we can have the right picture, that will also inform the decision that needs to be put in place in the country. So now let's come back to this presentation and talk a bit about the reservoir host of the monkeypox virus. The answer here, if someone asks you, what is the reservoir of monkeypox virus? Please, we do not know. We are not certain that it's these animals that we are showing here, but we suspect that it could be the giant Gambian patch rat, okay, which is native for Africa, found in forested areas and agricultural fields. And so we also suspect that it could be the squirrel, the rope squirrel, and the African tree squirrel, because many hunters actually will go to hunt for these. And in a few investigations that were made, some of the cases that came positive will just tell you that they were in contact with these animals. But yes, a few monkeys were also found to be positive to monkeypox virus, but it's not with certitude, with certainty, 100% certainty, that we can say that those monkeys are the reservoir host of the monkeypox virus. So there are some rodents that are also incriminated in this case. But again, we are just taking these as assumptions, but while we are responding in terms of interrupting the chains of transmission, I think we apply what we can also say the no regret policy. So we just need to advise our populations in rural areas, in forested areas, to avoid, close contact with these animals and to use IPC measures. And there will be a session actually on this when our colleagues from infection prevention control will come in the next week's sessions to talk to you about that. Now, someone was asking a question: what is the incubation period of mpox? So generally, it ranges from 2 to 21 days, with shorter or longer period occasionally noted. But remember that the host, which is the human who maybe carries these viruses, can also be able to determine the incubation period depending on his human status. So usually the onset of symptoms is usually 6 to 13 days, but it can also vary from 5 to 21 days. But now we have also noted that during the 2022 to 2023 outbreak, the current one, the incubation period became shorter than what was observed previously. So there are still studies that need to be done, actually, to follow up some of the suspected cases and to do a close follow-up on contacts so that we can be able to determine what is the current incubation period, stratified probably by the type of clades that we have on the ground. So the shorter incubation period could be due to various factors, as I said, the differences in the various strains, the methods of data collection, but also the patient demographics. And a bit on the transmissibility of mpox. So the dynamics are not fully elucidated. So recently, observations have suggested that the mpox virus in the settings of the 2022 to 2023 outbreaks is widely transmitted through human-to-human contact. So it just stops to be just a zoonosis, but it now goes beyond that. And so this will include, sexual and not sexual contact. And we also have to tell you that the mpox virus has been found in semen, in the vaginal fluid, and in rectal swabs. So what we also know so far is that people with mpox are infectious until the rash is completely healed 2 to 4 weeks after. So you need to have this in mind, and our colleagues of case management will come back with details on this. And the person exposed to someone with mpox could develop symptoms up to 21 days afterwards. So we have also noted in terms of the dynamics of transmission, there was a nosocomial transmission, which occurred in healthcare settings. We have witnessed that in Kinshasa in the DRC, and this was through contact with contaminated medical equipment or surfaces. So healthcare workers may be really at risk if appropriate infection control measures are not followed. So I mentioned that the mpox virus has been found in semen, vaginal fluids, and rectal swabs. So there is also a vertical transmission from mother to child. So the mpox virus can be transmitted from a pregnant woman to her fetus during pregnancy or childbirth. So the exact mechanism are not well understood, but may involve the virus crossing the placenta or just exposure to infected maternal fluids during the delivery. So here is a table chart that is giving us, the transmission type and the exposure, that what is the association between them, and what is rather the correlation between the transmission type and the exposure type. So we can see that through sexual encounter, especially in the last outbreaks, it's quite strong, where we have most cases, when it's darker, it means that we have most cases were just transmitted through sexual encounter. okay? And then from person to person. So this is important actually to know. But there are others here, like maybe from occupational exposure in the laboratory, mother to child at pregnancy or birth, or healthcare associated transmission, and contact with contaminated materials anyway. So this is quite important. But we have also seen that it was quite strong when there is a party with sexual contact, okay? The exposure was quite high there to the virus, and also in a large event with sexual contact. This is for the last outbreak. Now, what are the factors that are influencing the transmission dynamics? Here we have to mention here the reservoir host ecology, the distribution and abundance of what we are suspecting now as reservoir host can also influence the spillover events for forest, for example, that are shared between the two countries or cross-border spillover event. The human behavior and the contact patterns, where we have close contact with infected animals, human increases transmission risk, where we also have individuals with new or multiple casual sexual partners. We have the men who have sex with men, bisexuals, or even gays. And in the eastern part of the DRC, we had so many cases in the professional sex workers. So we also have the density of the population. High density can also lead to an increased contact and transmission. We also have transmission through in healthcare infrastructure. If there is no available or quality healthcare, that could also affect the detection and the management of mpox cases. The public health interventions, the social and environmental factors, such as the climate and habitat changes, can also affect the reservoir host behavior and the distribution. And this has explained, I think, some of the outbreaks that we had in Nigeria, but also the immunity and vaccination. There is someone who asked a very good question. So it is suspected that the fact that the smallpox vaccination was stopped in 1977 or 1980s could now explain why we are having a resurgence of a surge or an outbreak of mpox, human mpox, because the smallpox vaccine actually was protecting against the mpox. But also the globalization and the travel, actually, they're taking just the virus from one place to another. Now, I think I'm going to end up with this slide where we have environmental and social factors that are actually, that could also explain some of the occurrence of this mpox. Places where we have civil unrest and people moving, poverty could also be a factor. And I've mentioned climate change, the cessation of smallpox vaccination, but also deforestation, where animals that could be the reservoir could come in contact with the communities. All right, so this is the summary. Everything that we have spoken actually into this presentation is resumed on this slide, where we introduced mpox. And I think there's so many issues that we spoke about, and this is only the beginning. This is only the beginning. There are more sessions that are coming where all your questions are going to be answered, but this is just in the perspective of just building capacities so that we can also go into our own communities and talk to our siblings, our brothers, our friends about mpox and the risks of contamination, so that everyone can open his eyes. And there will be a colleague who will talk about community-based surveillance, I think, in the future, and it will answer some of the questions that I saw in the Q&A. Let me stop here, Chair, and take the questions as they come. Over to you. Thank you.
Yes, thank you so much, Dr. Mitchell and Dr. Diallo. Very, very deep insights there from your end, talking about the epidemiology and the transmission move, the reservoir and the mode of transmission, the risk factors, what can we do? Very, very interesting. Thank you so much. Now, we want to make this webinar interesting. If you wish to ask your question live, there is opportunity for it. I'm seeing some hands up. So if you, maybe the technical end, you have to help us to unmute the microphone of the participants. Let's listen to you live. You are very free to speak any language of your choice because we have interpretations in all languages. If you want to speak, please let me just see. We are going to allow 1, 2, 3 people before I read 1, 2, or 3 questions that are also have been posted in the chat group as well. All right, thank you. Norbert Soke, I think I've chatted with you before now that I will recognize you. Can you please speak up and ask your questions? Yes, to Dr. Mitchell and Dr. Diallo. Yes, please go ahead.
Okay, thank you. My question is with Dr. Michel. I think when you talk about the genetic changes that happen with the virus, I think there was a report in Kamituga talking about like some changes with the nucleate. Can you talk more about what you know about the situation in Kamituga? Over.
Okay, thank you. Thank you so much. Please, the panelists will be taking note of the questions, and the response will come after taking few of these questions. Can I call on Foseni Dembele? Sorry if I'm not pronouncing your names correctly. Foseni Dembele, please go ahead and ask your question. Dembele, are you there? Okay. I guess. Dembele? Okay, hands down, I guess. All right. Please, can we meet Andre, please? Oh, all right, thank you. Thank you. Gift, Annie Young.
Yes, good evening, everybody. The presentation was very detailed and quite interesting. And I'm calling from African CDC HQ. I just have some few comments. During the presentation, we were told that 2,717 cases were reported in 10 African countries, and with 22 deaths. But the last presenter also gave an overview of what is happening in DRC, that we had 5,133 cases and only 873 samples were collected and tested for mpox, with about 70%, 70 persons confirmed positive. My question is that the information that has been given is not adding up to the 2,117 cases, and it's a bit confusing when you look at the global details that were given and that of the DRC cases that were reported. So I would really like to gain more insights on this discrepancies on this the data that has been presented. Thank you very much. I appreciate it.
Thank you, Gifts. Thank you. The panelists are taking note, our presenters are taking note. The third person I want to call for live question is Muftau Akipelu. Muftau, are you there? Muftau Afolabi Akipelu, are you there? Your hand is up. Can we please unmute him? If it's not...
Yeah, he's unmuted.
Okay.
Somebody has asked that question. Hello?
Oh,
somebody has asked the question. Thank you.
Oh, thank you. Okay, thank you. Thank you so much. All right, just a few questions to add to what the live questioners have asked. is that just picking them according to how they were posted is maybe this is to Dr. Michel now. How many clades are circulating in DRC? And is there any mutation of clade 1 which has made it more sexually transmitted? That's one notable question. The second one I want to pick from here is, are there any African MS, which, I don't know what this person means by MS, maybe member state, yes. Are there any African member states which have integrated mpox to their surveillance system? Can you share their experience? All right, to Dr. Michel and Dr. Diallo. Another one here, maybe that I will stop there because of time, is that 96% of contaminations are male and 85.4% among gay. And the question is it to say that the transmission is more sensitive by sexual way? Can we conclude that? Thank you so much. Dr. Diallo and Dr. Michel, over to you or your responses.
Je m'excuse, depuis qu'on a levé la main pour poser la question, on n'a pas la parole, je ne sais pas. C'est le docteur André depuis la République démocratique du Congo. On a levé la main pour poser des questions, mais on n'est pas...
Okay.
La parole ne nous est pas donnée.
Oh, who is that, please? What's the name, please? Hello.
I see
Okay,
it's
André Mbeko depuis la République démocratique du
Dr.
Congo.
Mbeko.
On a levé la main pour
please
poser
go ahead.
Une question.
We want to hear from your experience because DRC is actually the headquarters of this discussion now in Africa region. Please go ahead.
Merci. Merci beaucoup de m'avoir accordé la parole. Je suis Dr. André Mbeko, de la République démocratique du Congo. Je suis médecin vétérinaire avec une spécialité en santé publique, filière épidémiologie de terrain et gestion de laboratoire. J'ai suivi avec un intérêt tout à fait particulier l'exposé. Ma question est celle de savoir, lorsqu'il y a eu arrêt de la vaccination, c'était parce que le monkeypox était à la phase de son contrôle ou de son éradication, alors qu'à travers le monde, nous savons que le monkeypox est presque demeuré endémique en République démocratique du Congo. Ça, c'est la première question. La seconde question, c'est celle de savoir, avec l'impact du changement climatique, la République démocratique du Congo, sur la réponse par rapport à son statut endémique concernant les monkeypox est valable. Pourquoi alors le monkeypox à la République démocratique du Congo n'était pas beaucoup plus en valeur? Son importance est aujourd'hui réveillée parce qu'il y a eu des cas sur le niveau international. Voilà un peu ce que je voulais savoir. Merci beaucoup de m'avoir accordé la parole.
Okay, thank you. Thank you so much, Dr. Mbeko Andre. Maybe one more person for live question. I can see more hands on. This time around, Pierre Shamashanga. Pierre Shamashanga, are you there? All right, okay, just to save our time. Is Dr. Balde, can you ask your question, please? Okay, hands down. All right, okay. I just want one more person. Maybe we can take, Balde, are you there?
Hello? Hello?
Hello, please, go ahead.
Hello? Okay, bonsoir.
Yes.
Moi, je suis Dr. Balde Abdourahmane. Je suis le médecin chargé de la maladie dans un district sanitaire de la Guinée-Conakry. J'aimerais savoir, en Afrique de l'Ouest, plus particulièrement en Guinée, si notre laboratoire est capable de faire ce test, de diagnostiquer cette maladie. Merci. Parce que j'ai vu au moins Libéria, le Ghana, le Nigeria. Le Libéria et la Sierra Leone sont des pays limitrophes de la Guinée. Et nous, en Guinée, on n'a pas détecté ces cas. Merci. On va donner la parole.
All right, thank you. Thank you so much. Now, we're trying to save our time too, because we're going to have one or two information to pass across. And just before the Dr. Diallo and Dr. Michel respond, let me quickly reiterate again that this is just the beginning of the 5-week webinar, and that most of the questions will surely receive answers in the subsequent sessions of this 5-week webinar series. So if you are not being recognized to ask your question today, or your question posted are not answers today, it's because we still have a long way to go in this webinar. And so we surely recognize more questions as we move on. Just to let you know that by next week, Tuesday, the same time, we'll be convening here on the same platform for another session of the series. At this juncture, please let me give the floor to Dr. Michel and Dr. Diallo for responses to these questions. Thank you, and over to you.
Okay, thank you very much. Thank you very much, Dr. Daniel, for this opportunity, and thanks to all the participants for these really pertinent questions. But there are some questions that will definitely find the answers in the coming sessions. For example, questions on vaccination. Someone asked why vaccination was stopped. Please remember that the vaccination that was done in the 1970s, it was the vaccination against smallpox, not monkeypox. It was against smallpox, and it was stopped, I think, by 1980, when smallpox was eradicated. But remember, when I was sharing and telling you about the genome, or the genomic structure of the mpox, it's similar to the one for smallpox. And that's why it is believed that at the time when the smallpox vaccination was, or immunization was implemented, it was also probably protecting against the monkeypox. So the first case or human case of mpox that was identified in 1917, the DRC, that child was not vaccinated against smallpox. So I think it's very important to put things in the context. So it was stopped because smallpox was definitely eradicated, and I think we don't even know it these days. There has never been any case since the 1980s that has been reported on smallpox. But then we started seeing, mpox coming in animals first, and then through contact with men, I think it's became, it was a zoonosis, affecting men, and as time goes on, it started being, human-to-human infection, and that's why we have now these outbreaks. And actually, for what is planned to be used as in the vaccination strategy, it's going to be again the same vaccine against smallpox that is going to probably be made available to the countries that, especially areas that are endemic. But my colleague from Afro will come and talk about vaccination against mpox in the coming sessions. Now, let me just quickly give an answer to my colleague from CDC, Gift. So what I said, globally, we only report, usually globally, we only report on confirmed cases of monkeypox or mpox. That's what we report, confirmed, laboratory confirmed cases. In DRC, they report on suspected cases. So mostly those that have not been confirmed by the laboratory. And out of those suspected cases, like cases that go just to the nearest health facility, the Congolese doctors are actually very good in recognizing these pathologies, because at 70% of the time, 7 out of 10 cases, they hit right on the diagnosis, Congolese doctors who are in rural areas. So it's I can say that we need to give them a round of applause, because they do not really go far from the right diagnosis. So based on that, they have been just reporting mainly syndromic, like, identifying those cases based on the symptoms. But because of the lack of resources, you do not have laboratories in all those rural areas. You do not have laboratories there. And sometimes for you to collect samples, you need to have skilled people who can make collections, from the skin to make sample collections and then send it to the lab. So it takes time because of remote location of those areas in the forest. But for teams that went to investigate, and the few resources, financial resources that have been given to the Ministry of Health in the DRC and in those district areas, they have been able to collect, let's just say, I think that the sample collection rate or the testing rate stands around, it's less than 20%. So less than 20% of the suspected cases are going to have samples that are collected. And those ones, when they are analyzed, tested for mpox or mpox virus, those that are positive, it's usually around 70%. There is an area where it even came to 90% in it's in the Equatorial province. So it came at 90% of the samples collected came back positive for mpox. But unfortunately, when they have not to report at the regional level and at the global level, we only recognized the confirmed cases out of those cases that were sampled. So that's why you might feel like the numbers are not tallying, but it's just that there is an explanation. But this is why we need to put in more resources so that we can improve the testing. Every suspected case should be tested. Samples should be collected and tested for mpox. And that's where we are going to have the real numbers about the burden of mpox in the DRC. So this is what I can say. I don't know if there's some other questions. Please, Chair, can you remind me if there are questions that need to be touched again? Because when it comes to case management, our colleague, Dr. Rashidatu, will come on that in the future sessions. I should not just go on that now. Dr. Daniel?
Yes.
Any other questions?
Thank you so much, Dr. Michel. Thank you so much. It's been brilliant responses from you. I think you've answered most of the questions. Probably you just want to touch on why we having 96% and 84.6% among the contamination for male and that of gay respectively. And the question is, are we saying that the transmission is more sensitive by sexual way? Is it confirmatory? I think that's the last question that you want to address now.
Yes. Okay, so there was another question to ask about what clades do we find in DRC. Okay,
yes.
So in the DRC, for sure that we have clade 1, and I think at some point we could have 2 clades, because there are cases that were also imported. People coming from Europe visiting the DRC in Kinshasa, and this was in a community of MSMs, males who have sex with males. We have found that, they reported those cases of clade 1. And even in the Kwango, it was clade 1. But I think we also have clade 2 in the DRC. I don't know if on the platform we have colleagues from the laboratory, but I think this question can also find its answers in the session that will come on the laboratory, because where we are going to look at testing and what is happening actually in different countries. Now, for a colleague who also asked if in their country they have enough capacity to identify mpox, please remember that we have case definitions that are available on the WHO website. You do not need to wait for for laboratory testing for you to suspect or find that this is a probable case of mpox. So you can have the signs, the rash, the fever, the history of the patient, and the history of contact. You are able to define if this is a suspected case, and a medical doctor who has been well trained will be able to say that this is a probable case of mpox if, for example, there is an identified contact who has been diagnosed with mpox in the area. But again, when it comes now to laboratory testing or confirmation of those cases, it depends on the capacity of the country, and our colleagues from the laboratory will be able to talk more about the capacities of every country in the region to be able actually to then identify, or to analyze the samples that are taken in their own countries. But what is good is, I think there is a task force team that is going to be created at the regional level. And this task force is actually going to coordinate the effort to respond to this outbreak regionally, and supporting every country that is reporting on mpox, but also every country that is at risk of having cases of mpox. And I believe that capacities in different pillars are also going to be enhanced so that we can be able to control this one. Yeah, so now I see that colleagues who are saying that in the DRC, it's mostly just clade 1, but I remember that when we were there, clade 1, yes, was identified, especially in the regions where that were not endemic. So we know that it was also clade 1. We were expecting maybe to see clade 2 coming from the West African countries, but it was not the case. But we still need actually to give a clear answer when it comes to that, when our colleagues from the laboratory are going to make the presentation. Thank you, and over.
Thank you.
Sorry. Now, okay. Sorry, Dr. Daniel.
Okay.
To the part where I think they want to know if the clade 1 is mostly transmitted through sexual contact. No, I think primarily we need to understand that human contact, direct contact, between two humans and one who has mpox could definitely be a source of contamination to the other one. So when people are having sex, of course, they come into contact, skin to skin. They come into contact. It could also explain why they developed that. But now, there is a new picture that we have seen, especially in the eastern part of the DRC, and even, I think, somewhere in the Congo, where people started presenting with lesions on the genital area. And we had actually to investigate what's the meaning of this. But we found that it was mainly associated to clade 1. And this is in the context where we have many professional sex workers who were actually operating around mining areas in the eastern part of the DRC, but also crossing other provinces. We found that, when we were studying, we investigating the chain of transmission, that there was like just, I would say, excuse me the term, but sexual promiscuity, where you have one person having different partners and each one of them started developing, the symptoms of mpox. And we understood that the sexual transmission in this case could be very, very possible. Studies have been done, by scientists, and they've shown that the mpox virus could be found in the semen, But above all, I want you, dear participants, to understand something. We are still maybe at an early stage of, research, or we need actually to improve in terms of research. There is a consortium that has been formed, which will definitely focus on research so that we can be able to answer all these epidemiological questions about the dynamics of mpox transmission in humans. So there is still a lot that needs to be done. Thank you, and over.
Thank you so much, Dr. Michel. Thank you, and thank you again. It's been very, very interesting having these interactions. And their colleagues, because we are all colleagues, all participants here are colleagues, and most of us, if not all, are responders to emergencies across Africa and across the world. Just as Dr. Michel has put it, that is why we are here. We're still trying to cross-fertilize ideas, but most importantly, what we intend to achieve with this webinar is for us to increase our knowledge capacity to be able to control it in our communities, and even down to villages and the creeks and cattle camps. So improving our knowledge in this regard, while we still bank on the researches that are still ongoing, then we want to ensure that the epidemiological trend, or may I put it rightly, that we need to start reducing the curves and probably possible flatten it in our African region. Thank you so much. Dear participants, I can still see some hands up. Apologies. From next week, surely we will be taking another sessions. And if I may just probably whet your appetite, we will be talking about I don't know if you can see my screen as we round up, just to let you know. The highlighted areas are the ones that will be coming next week, 38th of April. We will be having interactive session 4, which is going to be talking about, we want to deep dive into surveillance and reporting, establishing effective surveillance systems so that we search all mpox cases out. We have a standby facilitators for that. We'll be talking about 5 as well, which would be the area of diagnosis and laboratory testing. I could see Dr. Michel trying to reiterate that next week would be for laboratory testing. And please, let's all come and invite others through the links that have been shared with us. We want to see more people on board in the next week's session. At this juncture, thank you to all of you participants and all our facilitators. It's been very interesting listening to you and the cross-fertilizing ideas. We will be closing now, and we want to register our very big appreciation to you all, and it's encouraging to see all of you on board, dear participants. We'll be seeing you next week again, the same time, and please try to tell others so that we will not be selfish about it. Thank you so much, Dr. Mitchell, Dr. Diallo. I don't know if you're still there. Thank you. A very big thank you to you, and thank you to Dr. Rosamond, even in her absence. Thank you. Thank you all. We shall be closing here, and we don't want you to have fatigue, and so we need to also watch our time. Next week is another time, and we shall all be gathering here once again to dine together in this wealth of knowledge that is very, very important for controlling and eliminating mpox in our region and even globally. Thank you. Thank you so much, everyone. Have a very good evening. Have a very good morning, and have a very good afternoon. Thank you all.